I'm Windsor Ting. I'm a vascular surgeon at Mount Sinai. I specialize in deep vein and superficial vein disease. I take care of a lot of patients with DVTs. So it's estimated that 900,000 individuals each year are affected by DVT PE. It's a pretty large number. And it has been reported that 25% of patients with PE, the first symptom is sudden death. This number seems awfully high to me. I think there are many PE patients who are subclinical and asymptomatic. So 25% death from PE is maybe a little high. And it also been reported that 60,000 to 100,000 individuals in America die from DVT PE on an annual basis. The treatment of DVT has really made some pretty dramatic advances in the last several years. The new medication that we use for these patients, DOACs, has really made a dramatic change in my practice. In year past, when I see a patient in my office with acute DVT, I would admit the patient, start them on heparin, and schedule the thrombectomy in about 24 hours, and then after the procedure, we'll load the patient on Coumadin, which will take several days to sometimes even longer than several days. Fast forward to present time, when I see a patient now with acute DVT, I will start them on a DOAC, and I know the patient will be fully anticoagulated within 4 to 6 hours. I schedule a patient for thrombectomy procedure if indicated within a week or two, almost on an elective basis. I don't stop the anticoagulation, and then the patient can go home the same day of the procedure, and sometime if I decide to infuse the patient TPA the next day after the procedure. So the treatment of this patient has dramatically changed over the last several years. And there are many outstanding thrombectomy devices available for us to use for these patients. Angiojet, I use a lot of Angiojet in my patient. Certainly Penumbra and Inari have good devices. And there are other excellent devices that we have access to clinically. As mentioned earlier, Maytherna is the compression of left common iliac vein by the right common iliac artery. It is by far the most common iliac vein stenosis. It's important to recognize that about 50% of patients, they have bilateral iliac vein stenosis. We also see stenosis in the iliac vein on the right side, right common iliac vein, and certainly in both external iliac vein, although less frequently. So when we see one of these patients coming to us with acute DVT, what do? The treatment is very much dependent on many different things. The acuity, chronicity of the blood clot, the extent of the blood clot, and the location of the blood clot, and certainly the underlying comorbid condition of these patients. I think for chronic DVT, the primary treatment is stent placement for these patients. We see a lot of patients with what we call a subacute DVT. We're not sure it's acute, and definitely not a chronic DVT. So there's a lot of these patients with what we call subacute DVT. So for these patients, it's a combination of thrombectomy and stent placement. The decision is guided by the individual case. These are all very different cases. So what you do is depending on what you find during the procedure. So this is a 25-year-old male. He presented with acute left leg swelling and pain. And if you look at the venogram on the upper panel, this patient had pretty extensive DVT. It started in the common iliac vein on the left, extended down to the external iliac vein, and further into the common femoral vein. And you can also see that this patient had a lot of collaterals. So it suggested there's a chronic component to this DVT, which is quite common. It's not all that common that we see someone with just isolated acute DVT. Acute on chronic is a very common finding in these patients. I elected to use angiojet thrombectomy in this patient. I select the device because I'm very comfortable using angiojet, having used it in many, many patients. And in the bottom panel, you can see, the vein is open. And when I did IVUS on this patient, I was able to see fair amount of thrombus, residual thrombus in the iliac vein. So I decided to infuse this patient selectively with TPA. I use 1 milligram an hour for about 24 hours. I find TPA infusion to be really quite good in reducing the thrombus load on this patient, even after you've done the thrombectomy. This is the venogram from the next day. It certainly looked much better than the day before. On IVUS, there was still a fair amount of thrombus in the iliac vein, and you can appreciate he has a fairly severe common iliac vein stenosis. So I decided to put a stent in this patient. I was concerned whether I was able to maintain the patency with just thrombectomy. I placed a 1690 millimeter wall stent, and you can see prior to dilation of the stent, there's a fairly severe stenosis in the midsection of this stent. In the upper panel, I was dilating the stent with a 60 millimeter balloon. And in the bottom panel is the completion venogram. It looked really good. Nice flow throughout the stent. And this patient I have followed now for many, many years, and he remained quite good after this initial intervention. This is another patient, 80-year-old woman. She presented with cold left leg and saddle PE. The saddle PE, she was pretty stable, so nothing needed to be done there. So on a day of admission, I did an open left common femoral artery thrombectomy, embolectomy, and then I suspected that this patient had a PFO, and that was confirmed with the bubble study. So about a week later, we did a catheter closure of a PFO, and 2 days later, I went in and did the thrombectomy on this particular patient. So with these patients, you don't have to do a procedure right away. You have that window of at least 2 weeks, possibly even longer, to do the thrombectomy in this patient. And the upper panel was the venogram on this patient. You can see the thrombus was mostly in the common iliac vein. And with IVUS, I saw the thrombus extended into vena cava. And she also has pretty significant stenosis in both the right and the left common iliac vein. For a case like this, there are several different approaches that you can use. I decided to do suction catheter thrombectomy on her. And after I did the procedure, the thrombectomy, the completion venogram and IVUS show there's still a fair amount of thrombus in her iliac veins. So what I did next is I put a stent in her. I decided to put bilateral iliac kissing stent, and you can see the stent is being deployed. This is another patient that I've been following over the years, 62-year-old woman. She is a world-class swimmer. She presented with acute DVT in her left. Oh, it was really extensive DVT. She came in with pretty severe leg swelling. And she had DVT from common iliac vein through the external iliac vein down into her common femoral and femoral vein. I did angiojet thrombectomy on her. And I did balloon angioplasty to press the clots against the against her veins, her blood vessels, and I infused her with TPA for about 12 hours. She did great. The venogram the following day show patent vessels. She did have a pretty significant stenosis in her left common iliac vein. And this patient clearly made it known beforehand she wanted no stent. And I still following this patient over the years. And this is a CT scan from 2024. And you can see she had a moderate stenosis in the midsection of her left common iliac vein. And this year, I had an opportunity to do a follow-up venogram on her. It's pretty amazing. So her iliac vein looks pretty good. Widely patent, no obvious stenosis. Although on IVUS, she's continued to have this moderate stenosis in her left common iliac vein. So the take-home lesson there is that some patients with acute DVT, and you find a May-Thurner or iliac vein stenosis, you may want to put a stent, but not everyone require a stent during their thrombectomy procedure. So how do we manage these iliac vein stenotic patients during acute DVT intervention? You do your thrombectomy procedure with using whatever catheter you're most comfortable with. I don't think stent placement is necessary in every DVT case. It has to be a selective decision. In some patients, you may want to do it. Consider stent placement if you are unable to establish patency of the veins with just thrombectomy. I am a big fan of TPA infusion. I find it to be very useful. If there's a lot of residual thrombus, I will infuse TPA selectively overnight and then bring them back to the operating room the next day. And if you think stent placement is indicated, determined by the IVUS during the procedure, you don't necessarily have to put a stent at the same sitting. If you think the vessel can stay open with just a thrombectomy, I would bring the patient back maybe a few weeks later, maybe in a few months later, to do the stent placement. I think stent placement in the setting of acute thrombus may not do as well. So there's an argument to wait. You don't have to do everything at the same time unless you are not able to keep the vessel open with just thrombectomy. Thank you.